Healthcare in Belgium, Wikipedia audio. Healthcare in Belgium is composed of three parts. Firstly, there is a primarily publicly funded healthcare and social security service run by the federal government, which organizes and regulates healthcare, independent private/public practitioners, university/semi-private hospitals and care institutions. There are a few private hospitals. Secondly is the insurance coverage provided for patients. Finally, industry coverage, which covers the production and distribution of healthcare products for research and development. The primary aspect of this research is done in universities and hospitals. Healthcare in Belgium is mainly the responsibility of the federal minister and the FOD Volksgezondheid en Sociale Zekerheid/SPF Santa Public et Securiteit Sociale. The responsibility is exercised by the governments of the Flemish, Walloon regions and the German-speaking community. Both the Belgian federal government and the regional governments have ministers for public health and a supportive administrative civil service. Appeals, Court of Labor, First Instance, Labor Court. Organization. Public health. Safety of the food chain. Ambulance services, firefighting services, including the Civil Protection Service, private subcontractors in case of emergencies or catastrophes, coordination of all emergency services during catastrophes. Environment. Plants and animals. Competent Minister for Welfare and Social Affairs, as of 2015 Herr Antonios Antoniadis, Minister for Family, Gezondheid und Sociales. Responsibility for Welfare and Social Affairs. The provincial authority is also competent for catastrophe planning and management of the emergency services. First line, the primary care function that is provided by physicians, emergency services, and emergency rooms in hospitals. Polyclinics provide non-urgent first-line care, second-line, acute and immediate care provided by hospitals for patients requiring technical interventions, and acute curative care, chronic or long-term care, is provided by rehab clinics, service flat care providers, old age homes, and home care services. In larger cities, these public services manage large budgets, with a substantial administrative burden. They operate hospitals, clinics, rehabilitation centers, retirement/pensioners' residences and daycare centers. The largest PCSW is the one in Antwerp. In 2013, it managed a budget of €461 million, and paid benefits to people with no or very low incomes, for a total of €125 million. The PCSW employs a workforce of over 1,000 people. Hospitals and other care institutions are grouped into a separate organization called ZNA. Employs another 7,000 people, and in 2010, had a budget of approximately €568 million. A recent decision by the Flemish regional government aims at abolishing this local authority service, which had a substantial measure of independence and authority from the political elected councillors. It will bring it under the authority of the communal council within the next 2 years. This decision is being contested by the opposition, and by legal impediments at the federal governmental level. Private practice. General practitioners usually operate from their private practice, although some group practices are emerging. These doctors are also syndicated in local chapters that organize out-of-hours services during weekend and holidays and for the evening hours and during vacations. A patient can call a duty GP 24/7 who has access to their medical records. Specialists, many combine their private practice with a hospital posting or with a teaching position or similar research posting. Only a few operate private clinics, experts and assessment consultants. These specialists don't see general patients, rather they evaluate patients either as a second opinion at the request of the patient or are appointed to assess patients and treatments for insurance purposes or by appointment by a court. Political and regulatory. Generally speaking, healthcare is organized in 3 layers. For common diseases like cold, flu, injuries and pain, patients contact their GPS. Physicians in private practice are generally self-employed. Officially, they are categorized in the following framework. Most doctors working in hospitals also have a private practice. Exceptions include neurosurgeons or radiologists because they cannot invest in the high-tech equipment required. Doctors are usually paid on a per medical act basis either by the patient at their private practice or by the hospital. Some specialists are employees on a hospital payroll or for research labs or universities. Assessment consultants are paid a fixed fee for their assessment report by whoever hired them. For accidents and medical emergencies, everybody can call on the emergency services. There are 2 phone numbers to contact the emergency services network, 100 or 112. 100 gives access to the ambulance service or fire department. In larger cities, the fire department operates the ambulances, elsewhere ambulances might be allocated to hospitals. 112 gives access to the police, ambulance services, and fire department. The dispatching centers for the 100 and 112 services dispatches an available ambulance from the closest hospital or ambulance center. The operator is qualified to decide to dispatch a MARE vehicle. Additionally, the Red Cross operates a number of ambulances, as do privately owned companies that operate ambulances for the emergency network. The Red Cross and a number of other cross charities own ambulances and have volunteers that man first aid posts during events like football matches, cycling races, sports or other mass events. They don't participate in the daily emergency services network, but they do liberate the emergency services network from allocating too many assets and resources during those mass events. Calling an ambulance is not a free service. The ambulance will bring the patient to the nearest hospital. An ambulance is manned by 2 people, a driver and a paramedic. Depending on the medical condition, a medical emergency response vehicle may be dispatched. That is manned by 3 people, a driver, an ER doctor, and a senior ER nurse. The ER doctor will choose the nearest appropriate hospital that has the necessary facilities based on the patient's symptoms and condition, or a hospital in which the patient is under active treatment. The Federal Service for Public Health describes the hospital sector in the following manner. Organization of care. Physicians. There are 2 distinct types of hospitals: general hospitals and psychiatric hospitals. Psychiatric patients are not mixed with the general hospital population. 68 psychiatric hospitals care for psychiatric patients that require care in a controlled, restricted environment. Some of these hospitals also offer therapy day clinics for patients that stay at home. 141 general hospitals mostly involved in providing non-surgical care for adults with services such as cardiology, pneumology, gastroenterology and endocrinology. They also provide a maternity ward, and most of them have an emergency response unit, 113 general acute hospitals, 7 are university hospitals directly linked to universities and provide for teaching and research facilities, 16 general hospitals with university status that have special provisions to collaborate with universities and colleges for teaching and research purposes. Emergency services. Hospitals. General structure. Nursing. Pharmacy. There are 209 hospitals. Day clinics where ambulant patients can have therapy and return home. Many hospitals have sections for day clinics, polyclinics where different specialists see patients who do not need to stay overnight in the hospital for diagnosis or post-therapy control. Many general hospitals operate polyclinics, but there are institutions outside hospitals that operate only as a polyclinic. The vast majority of hospitals are publicly funded. They are independent units or part of a larger organization that get funding from the public health service based on the activities they deploy, number of beds operated, specialist knowledge, etc. In Belgium, there are only a handful of privately owned/operated hospitals that work outside and without the public health service funding. They provide luxury services and luxury accommodation for patients that can afford such exclusive services. Emergencies and trauma center usually backed up by an intensive care unit, operating theaters, polyclinic consultations, ambulance or outpatient care. Patients can come during office hours to see a specialist either in the diagnostic phase, therapeutic phase, or post-therapy follow-up consultations, technical diagnostics such as collection of blood or bodily fluid samples, and lab testing, medical imaging, X-rays, CT scan, MRI or ultrasound, EEG, ECG, and extended monitoring outside acute illness situations, nursing units, standard hospital ward type of sections where patients get 24/7 care, post-OP recovery. Specialized units may be sections in a general hospital, independent units within a general hospital or independent specialized clinics, neonatal and pediatric clinics, rehab and recovery clinics, geriatric clinics, palliative care units, psychological assistance units. Healthcare Belgium is a non-profit organization established in 2007 by 6 prominent Belgian hospital groups with support from the medical technology industry in Belgium. Nursing in hospitals. In hospitals, the nursing work ranges from basic care nurse, nursing assistants, full nurse, chief ward nurse, trauma nurse or paramedics, or nurses and chief nurse. Each of these positions require a different level of formal training, on-the-job training, accumulated experience, and responsibilities. Nurses seldom work over their competence, because according to the Peter Principle, it would cause casualties. Nurses in care units work shifts 2 or 2 shifts/day and 365 days/year. Many nursing wards in general hospitals are currently chronically understaffed, exceptions being ER, or an ICU. Some post-surgical wards such as cardio, thoracic and neurosurgery units that operate MCMUs often are less prone to understaffing because of the risks involved for patients. Nursing in research and polyclinic environment. Nurses in research and polyclinic environments often have a more family-friendly and limited 5D/W8HR/D working patterns than their counterparts in the hospital care nursing units. However, not all nurses like to work in such environments. Ambulant nursing. When patients go home, they often require follow-up of their hospital care like wound dressing, injections and bathing. Specialized ambulant nursing services provide such nurse-at-home services for recovering patients and for elderly people living at home. These services also dispatch basic care nurses, that do not perform medical acts for patients and elderly that require help with their daily hygiene and changing. Health insurance. Outside these categories there are: in a general hospital, any of the following departments may be at the disposal of patients, but not all general hospitals offer all these facilities and departments. Different levels of nursing training are available: basic nurse, midwife, full nurse. Internet medication. If a patient buys medication in another EU country from a pharmacy for his personal use, by prescription, or over the counter, he can import them into Belgium in his luggage or vehicle. Belgian patients may legally buy over-the-counter painkillers such as paracetamol in the Netherlands where they are cheaper, and take them to Belgium. However, attempting to import prescription drugs without a prescription, unregistered or forbidden medication, or narcotics purchased on the internet or for recreational drugs illegally on the street is prohibited, and customs and police track this business rather strictly. Illegally imported drugs are confiscated, and the carrier might be brought to justice and fined or imprisoned. Health insurance is only one of the pillars of the system of social security provided for every Belgian citizen. Every Belgian citizen has access to the social security system. It is compulsory, but there are gaps in the system where people can drop out. For example, not paying contributions is one such exit, and another is homelessness. Every wage-earning worker or employee in a factory, office, working as house personnel, and anyone working in Belgium is registered to a central system, as well as the unemployed. The self-employed, such as shopkeepers, innkeepers, lawyers, and doctors, are also registered. Workers are paid a daily or monthly wage, their gross salary. From that gross salary, their employer has to deduct a certain amount for social security and another for taxes. The employer has to pay these amounts directly to the Social Security Services and the Inland Revenue Service. On top of the gross salary, the employer has to pay an employer's contribution for Social Security of approximate 15%, 22% to the Social Security Services. Failing to make these payments regularly and on time is closely monitored and often causes failing businesses to be taken to court for failing to comply with their social security and fiscal obligations towards their workers. This reduces the risk for workers when they remain unpaid or when their contributions are not paid for them. The self-employed have a system in which they have to declare their earnings, and based on their earnings a contribution is calculated, which is roughly 20%, 22%, but they are not covered like workers. People can opt into the system through this self-employed scheme. The government forms its tax earnings finances in part the social security system. This is a wealth redistribution mechanism. Because the contributions are incremental, this means that the more someone earns, the more this person will contribute. Moreover, for health services, the compulsory health insurance and the refund system is the same for everybody, i.e., for a consultation at the GP everybody pays the same and gets the same refund. History. There is a complementary system of health insurance offered by the mutualities, available to all mutuality members, and there is private insurance with commercial insurance companies for extended care and for travel care. These systems are pure premium-based insurance system. 1. Consultations with GPs or specialists in their private practice. Patients pay a fee for the consultation and for any medical acts he may perform directly to the doctor, In return, the patient gets a receipt that lists all the medical acts performed, and if necessary a prescription for medication. The patient gives this receipt to his mutuality, and they refund the patient in part. Average patients get about 75% refunded. Some patients have a special social security code. They pay only €1 to the doctor, and do not receive a refund receipt. The doctor is paid directly by the mutuality. The patient takes his prescription to a pharmacist, paying only part of its price. For each medication dispensed, the supplier is paid a supplement by the Social Security Services. In some cases the medication requires extra checks, and such medication is often free to the patient, although very expensive. Each sale of the medication is tracked, and the supplier paid by the Social Security Services directly. Working. 2. Consultations at hospitals. Patients see a doctor at the hospital polyclinic, just like in their private practice. Some patients pay the hospital as they leave and get a receipt for their mutuality, just like in a private practice. However, many patients come in for follow-up consultations after a medical intervention or hospitalization. The hospitals send the bill to the mutuality and patients get invoiced for their personal part. 3. Hospitalizations and medical interventions. Patients are hospitalized and they have to pay weekly advances for their medical expenses. All consultations and interventions, medications etc. are directly invoiced to the mutuality and to an insurance cover the patient may have. They receive an invoice for their personal part, which is often in part refundable by their complementary insurance. Patients who suffer accidents might never have to pay any medical expenses, as accident insurers are often charged immediately, once responsibility is established. Financing the system, compulsory Social Security. Financing the system, complementary systems. Covering healthcare costs. In the 1980s an SIS card was introduced, the Social Security card. With it the federal government introduced a national number, that identified each individual uniquely based on his/her birthday. Every individual had such an SIS card, and it established their entitlement to Social Security. In 2014 that system was superseded by the plastic ID card with Social Security information on a card chip, readable with a simple card reader. According to the Euro Health Consumer Index, which placed it in 5th position in its 2015 survey, Belgium is probably the most generous healthcare system in Europe. Social Security encompasses health, old age pensions, unemployment, disability and handicap, both managing the finances, but also the management of different kinds of care, regulation of the market of medicines, health and safety at work, health and safety of any public service rendered to the general public, monitoring and safety of the food chain etc. Managing healthcare money streams. Patient identification. Social Security.